So good afternoon, everyone. I would like to welcome you to this 22nd Complex Coronary Intervention webcast. It is a great privilege today to have with us Dr. Bill Nicholson, one of the world's best CTO operators, who is going to talk to us about saphenous vein grafts in CTO PCI, which is actually an area of rapid development lately with a lot of controversy, which will come through his talk. Dr. Nicholson is the Director of Interventional Cardiology at WellSpan Health. It is actually his father is there as well. It's a long line of Nicholsons that have done a phenomenal work up in New York, and is a great operator and a great friend. And we're very excited to hear about your presentation. And just to remind everyone to thank our sponsors, who's the Dallas Visitors Corporation, as well as Abbott Vascular and Terumo. So, Bill, thanks again for making this presentation today. We're very excited to go over things.
Well, Manus, thank you very much for inviting me. It's always a privilege to be a part of anything you're doing, and it's very much appreciated. So thanks for the introduction. It's very nice. I'm going to talk about saphenous vein graft usage in CTO PCI, and like Manus had mentioned, it's particularly relevant right now. There's some literature mounting on this, and it's becoming more and more of an option that most CTO operators are starting to use and using with more proficiency than maybe what they did before. Vein graft, presence during these cases is very common. Almost 20% of all the patients that are getting PCI done have had previous CABG done. So there are conduits. There are either degenerated vein grafts, diseased vein grafts, or even chronically occluded vein grafts that we can utilize. And the main way you're using them, and we're going to come back to the presentation that Stefan Rinford had at TCT last year that talks about his experience with using vein grafts as retrograde conduits. But really what we're talking about using the vein grafts is not to actually fix the vein graft itself, but to use the vein graft obviously as our retrograde conduit. And so the hybrid algorithm is what most of us have used as our guideline to sort of walk us through the initial strategy for CTO PCI. And I would argue that even with vein graft presence, and particularly, if it's a degenerated or severely diseased graft, but even in the case when it's a completely occluded graft, that maybe retrograde moves up a little bit in your hybrid algorithm strategy, just because of the readily available utility and the ability to get retrograde. It really does change your willingness to use this. And so when we think about retrograde options, whenever we get into a retrograde case, we always sort of traditionally thought about septal collaterals versus epicardial collaterals. And, septal collaterals, we all know, is anything that's LAD to PDA or PDA to LAD, and anything that is not LAD to PDA or PDA to LAD is considered an epicardial collateral, at least at some point in the travels that collateral is made to go from its donor vessel to its, from its parent vessel to its donor vessel. So that would be all others, and the relevance of that is obviously the fact that septal collaterals in general are safe to work in. It's not some place that you're going to get into issues when you traumatize the connections, and you don't really end up ending in a situation where the patient's going to tamp a knot and have other issues. Now you juxtapose that to epicardial collaterals, which are very unforgiving, and so epicardial collaterals have been traditionally kind of reserved for operators that have gotten 50 to 100 retrograde cases under their belt, and have become comfortable with the concept of retrograde, comfortable with going retrograde, and most importantly, comfortable with dealing with the inevitable consequences or complications that you will run into doing retrograde CTO PCI. So I think what's interesting, though, is, and this is a nice illustration that Manus had in an editorial that he invited me to write with him that has, sort of the traditional thought processes of how we think of retrograde options, and traditionally, we think of retrograde options being, ipsilateral collaterals or contralateral collaterals, but really bypass grafts are oftentimes some of the nicest and the easiest connections to use. So it sort of changed our thought process, at least in my world, that when I start thinking retrograde, I actually move saphenous vein grafts, either open, work functioning grafts or dead grafts. I've moved those up to the top on my list as far as strategies that I would go with. And so we typically, and I don't honestly much care whether they're TIMI grade 0 or not. So if they're completely occluded, that's one issue, but if they're not completely occluded, you still have a very good chance of being able to utilize the graft as your retrograde conduit. And so when we look at these, and this is what I think is probably helpful, and this is in experience, there are certain grafts that are readily approachable and there's certain grafts that are not or less favorable. And apologize for the dinging. Somebody's calling in on the other line, and I have no idea how to get rid of that line. So if I do something, I'm going to hang up on everybody. But when you look at this appearance here, you can have a bowl shape. This is very analogous to what we talk about when we assess caps for a typical CTO PCI. You can have caps that are blunt, or you can have caps that are rounded off. And so these blunt caps are often hard to engage, and it's hard to get something started down the graft when it's like that. When you get more of a beak like you have here, or more of an entry into it, they become much more favorable and much more easy to use. And if they have a little bit of residual lumen just starting down the graft itself, they often are very easy to use, and they're surprisingly easy to use. Even if they've been, I've had a number of patients that we've done that have been occluded for 10 years plus, and you can still use the grafts pretty easily. I'm going to go through how I do these, and then I have a series of cases that I'll show you that kind of demonstrate some of the little tips and tricks, and we can talk a little bit then about, management of the residual graft, as far as to coil or not to coil the residual graft, and also along with that, the fact that even though this seems like a safe conduit because it's a non-functioning conduit that you're using, so you don't run into the concerns of whether or not the patient's going to become ischemic or develop if they're teetering along with some depressed EF and you sit in a epicardial collateral, you oftentimes worry about those patients decompensating and ended up in heart failure. That's obviously not a concern when you're in a non-functioning graft, but they are not without potential complications and consequences of their own. And so we'll go over some of the ones we've managed to stumble into some complications, and I'll show you that. One of the biggest things, so for the grafts, you are going to need pretty good guide support. For in some cases you don't, but in a lot of cases you really do. I still go 8 French with these. I still do these from the leg, and I typically, for the rights, I typically use a multi-purpose guide. For the left grafts, I like an AL 0.75 for my graft or for my guide choice. And I think one of the things it's really paramount in all CTO PCI, and for that matter, all complex PCI. But I think in these cases as well is liberal use of guide catheter extension. And the 2 choices obviously that we have are the guideliner series that we have a 5.5, a 6, and an 8 French guideliners, and then you have Guidezilla, which is a 6 French system. I'm going to show you a case here in a minute that demonstrates what it was a case that Dimitri Karpaliotis and myself had done together. That demonstrates what we coined a mother-daughter-granddaughter approach, which is it's in publication. It's going to be coming out sometime soon, but it's an interesting strategy for getting even greater backup support, and it's useful both. Again, I've used it in non-CTO PCI, but we've got a nice case I'll show you here that shows how to utilize that, and we'll run through that. Microcatheter choice in these cases, this is typically a standard strategy or standard approach that you would use for almost all CTO PCI. So that means you have to use a microcatheter, obviously, and you're usually backing up your typical type of wires that you use. And so for me, microcatheters, I'm pretty liberal with the choices. I think the Corsair, the Turnpike, and the Micro 14 are all very good for this. You've got 3 choices with the Turnpike really nowadays that people are using in these kind of cases, and they have to be 150, obviously, because you're essentially doing a retrograde case, so you're going to have to be able to reach the native vessel, which would be the receiving guide. My choice, I typically use either a Turnpike LP or I end up using a Micro 14 for these cases. But the Turnpike LP is a little bit lower profile. I think makes the bend when you get down to the anastomosis, it makes that turn a little bit easier than the traditional Turnpike. The Corsair is very good as well.
Can I ask you any reason for using the original Turnpike versus the LP? Because people are asking that. Do you use everything now Turnpike LP, or do you still use the Turnpike proper sometimes?
Well, it's a good question. So I've got a couple issues with that. So for my antegrade cases alone, most of the time I'm using a Turnpike spiral actually as my baseline initial catheter. I do like it. I think it does allow you to dig a little bit into the proximal cap. It anchors you to a degree, and it gives you a little bit more push. And I think it does drive through some calcified real resistance segments that other catheters had not in the past. So I've kind of, just in my own personal habits, have transitioned over to a Turnpike spiral as my antegrade catheter in typical antegrade CTO PCI, not necessarily for vein grafts. most of my retrograde stuff, I've gone to a Turnpike LP, which I think tracks really well, and it does a nice job of making the bends and the turns. Micro 14 really does that very well as well. I've been impressed with that. The Turnpike LP kinks, which is the one thing I think people need to pay attention to, it does, whereas the Corsair did not. The Corsair would have some of the issues with the braiding and maybe lock on the wire, but the Turnpike LP will actually kink on itself, kind of like a telephone cord, and you just need to be wary of it. It's not a big deal, just you need to pay attention, because what it'll do is it typically will do that if you have your wire back for some reason. So if you pull the wire back and you're trying to back a Turnpike LP out and you're spinning it while you're doing it, you don't have the wire inside, and it doesn't keep it from coiling. But I've seen them coil, basically telephone cord and go down, big, other vessels. I've seen it happen in the guide itself and sort of lock itself in position. So it's one thing to be wary of. I don't know, what have you done? Have you switched over to Turnpike LP as your retrograde, or do you still use the typical Turnpike and the Corsair, Manus?
No, great point. Actually, depends. I'm more and more switching to LP as the primary one for retrograde. I do also used the Micro 14, and I like it as well. We just have some local logistic things for obtaining it. But I agree with you. We had a webcast. Last one was with Kambis Masayeki, who does all the lateral epicardial. And he also uses essentially exclusively Turnpike LP. And I had a case just yesterday. I was on retrograde with the Corsair, and the Hypo got stuck, had to change, and the Turnpike LP just flew through. So I don't know. I'm switching more and more because our Catalan manager wants to stock fewer things. So now we're stocking mainly the Turnpike LP. But
I think for me, honestly, I think I've used a Turnpike LP as my retrograde catheter probably in the last 35 cases. So I don't think I've pulled anything to go retrograde in a few months. I think it's very good. So this is just sort of a slide showing some of the comparative sides, but you can see, and we don't have Caravella. I'm sure you've used it somewhere, Manus, but we don't have it obviously in the States yet. But
actually, we do. It's available. It's now limited release. I think actually it's becoming a global release right now. That's pretty good as well. It's very similar to LP. It goes many places. You cannot spin it, but it goes many places. Yep.
So that's just more on the Micro 14. I think this is, and I don't know whether you're using a lot of these or not. I've sort of fallen in love with this 120 angle Supercross that Vascular Solutions makes. I think you have to have these for these vein graft cases. And the reason being is when you get to the distal anastomosis, it can be extremely difficult depending on how the surgeon, I'm going to show you, depending on how the surgeon sewed the distal anastomosis in. So, you basically have sort of three potential options you're going to encounter when you get down to the distal anastomosis. And a lot of times you'll see when the surgeons, have tented up the vessel, particularly on the left side when they do the circumflex, but you'll see the vessel kind of get tented up. But you see it from time to time on the PDA as well. Those typically are pretty easy because you've kind of tented it up and you end up with more of this T conformation of when the vein graft comes in. And you can easily, remember, you're going to have to you want to go retrograde. So, you got to access the vessel heading back north towards its origin rather than going down. And so when it's in this position, it's pretty easy to just wire straight up there. And when they haven't tented it, it's more like a T, again, can pretty reliably wire it. But these ones, when they V it in, when they end up sort of angling it so it's sort of a confluence that pushes you down towards the distal vessel, can be extremely difficult to flip your equipment up antegrade. And I think, to use the 120 Supercross, it's great. I'll show you a number of cases that we have that I'm going to show you here that shows how that happens. You go down just past the anastomosis, and you treat it much like a little JR4. You just clock it around till you get it in the right position, pull back a little bit, and it tends to hook right into the proximal vessel, and it gives you enough support to wire antegrade up. It's surprisingly, even with that bend, will track pretty well. Most of you think that 120 angle would cause it just to prolapse, but it does track pretty nicely and follows the wire. So I like it. I like it also just from talking about vein grafts, but I've used it where you might have used a venture catheter in the past or things like that, to select some of those difficult to access septals that kind of have a retrograde or retroflex entry point, and so you go down past it in the LAD and you can hook those and get into some septals that would have been pretty difficult to access otherwise. So it's something to keep in the bag, and I think for these kind of cases it's really important. Wire choice, and this is just talking, obviously the graft is open, you can use whatever wire you want and you're going to wire down through it without any trouble, but if the wire is a chronically occluded, the graft is a chronically occluded graft, For me, I typically start out with a Pilot 200 again with sort of a CTO bend on the wire, backed up with. For me, if I was doing a case traditionally, if we were doing a right, I'd have, likely a Turnpike LP backing up a Pilot 200. If you don't progress, it's the same kind of wire escalation that we would normally do up to a Confianza Pro 12. Again, being very wary or reserved about tracking the Pro 12 because it certainly not have had the Pro 12 leave out the side of the vein graft wall as easily as it leaves out the side of an arterial conduit, and I've had it go straight through the wall of the aorta as well. So I think you just have to be very wary about where it's going. A lot of times, if you again lift up a potential avenue or potential channel with the Pro 12, you don't really need to track it. If you pull it back, you'll be able to select that same channel with the Pilot 200. And be able to explore it a little bit more with a little bit more enthusiasm about tracking a microcatheter behind it so that you're not putting a real hole in the vessel wall. I've used Gaias in these a lot too. I like Gaia seconds and Gaia thirds for these. Again, escalating up to the 3 to the third if you're not making progress and then shifting back down. It's a fairly typical appearance when you wire it correctly. You're going to oftentimes, and I've got a couple of the fluoro saves that'll show you what the wiring looks like, but it typically when it's right, it's much like when a septal's right, it just goes, and you'll see as opposed to septals and other things when you spin the tip on this wire as it's traveling down the vein graft. Usually there's a heavily diseased occluded segment of the vein graft, and as you get free of it downstream, the wire tip will helicopter and tell you that it's free and it's in the true lumen. It is possible to get subintimal in the vein grafts, and it is possible to follow that subintimal plane into the target vessel. So so just because you pass down to where you think the target vessel is, you do need to have some confirmatory shots from whatever your donor channels are going to be able to confirm that you're true lumen, because it certainly has happened, and I've had that happen myself. And I'm not quite sure how honestly it's able to stay in the subintimal space past the anastomosis and the suture ring and all that kind of stuff, but it finds a way to do it. And so just be wary that just because you got to the target vessel doesn't mean you're actually in the true lumen.
Do you ever loop the wire there if you start and then just loop it, or you just avoid looping just to avoid exactly what you just said?
No, well, so to pass down through the graft, we certainly knuckled through the graft. I'm a little reserved about knuckling. You basically would be kind of more or less starring out the other end of the graft into the target vessel, which probably would work. But I think, it's at the penalty that if it doesn't go into true lumen, you're going to really, compress and beat the vessel up pretty well down there. So, but I don't know. Knuckling in the mid graft, I'm very comfortable with, and to progress like where you're not getting somewhere. Usually the wall, I guess, is thinner in the veins as well. So, I think even if you knuckle or get subintimal, you tend to find, especially if you're using a sharp wire like a Confianza Pro 12 or something like that, you tend to be able to find your way back into the true lumen. Have you knuckled into the distal anastomosis, through the distal anastomosis, Manus?
I have, but I had exactly the same experience you had. I had an experience where I liked to knuckle, but then one time it went subminimal, and that was a disaster. Then you couldn't, cause excessive dissection. So
yeah,
I very much, but
I have a picture at the end I'll show you of a knuckle graft related
to that. I don't know if you've had the same experience. I had the experience where you actually go undergrade, you cannot get through because you have an anastomosis of a graft you don't realize is there. And then the whole thing is stuck, and then you realize later on there was a graft and a touchdown going there. I don't know if you had the same
yeah. This is the one time where when you arrive at the distal graft that I think it is worthwhile doing a tip injection. So, kind of tip injections or distal tip injections are kind of taboo with almost everything we do in CTO PCI. But that's not what you're doing. You're not using it here to confirm true lumen or anything along those lines. You're using it here to undo the distal ambiguity that you're arriving at, and you'll be able to see what the anatomy is down there and give yourself an idea of where you're actually going to have to try to wire retrograde. Old films are very helpful in these cases. So if you have old films where the graft was open and now it's closed and you're doing the CTO of the target vessel, it's extremely helpful to be able to tell exactly where the surgeons sewed the graft in and what kind of angle you're going to be encountering down at the distal vessel. So, I think it's, even if it's 10 years old, it's worth going back and trying to find those. Let me show you this mother-daughter, granddaughter strategy of what we're talking about with this, and I'm going to show you that in a case that is not a CTO, and then I'll show it to you in a case that is. This is a case that we did just a couple weeks back that has a very heavily calcified, tortuous, heavily diseased right. It's got multiple lesions throughout it, and so we had started out with an AL, I believe that's an AL2, and I was going to rotoblade this up front, and believe it or not, our 25-year-old rotoblader here, the console broke, and so we nothing broke with the actual procedure, but the machine wouldn't work, so we didn't have a rotoblader. So this case, I'm not sure it could be done without this mother-daughter, granddaughter approach if you didn't have a rotoblader. And so what we did is we wired downstream. And if you look up at, I'm going to pause this for a second, but if you look up here, so we've got our guide in place. And what the mother-daughter, granddaughter situation is, we put an 8 French guide liner inside an 8 French guide, and then a 6 or a 5.5 guide liner or 6 guidezilla through the 8 French guide liner. And what you do is you use this kind of telescoping inchworm technique to drive the second guide liner out. And so you're basically getting dual backup when you do this. And so if you watch here, what we did is you're going to see, I actually had stented because I beat up the ostium at the beginning, so I stented the ostium up front just so I didn't have to run into issues with an ostial guide dissection that propagated back. It was disease and going to be treated either way. But what we do here is we had, that's just showing that part, but so we've got a balloon inflated. This is how I like to track guide liners. But so the balloon's inflated. It's a 3.5 balloon, and as it goes down, you're going to see just sort of telescope the guide liner over top. So watch, this is the 6.6 or the 6.0 guide liner at the beginning, and so we're going to telescope that over and down to the mid vessel. And once that's down, you're going to be able to telescope the 8 French guide liner out into. So you're going to see here. So here comes the 8 French guide liner behind it. And we can take that up around the elbow. And then we're going to just continue to do this kind of inchworm technique where I've got the balloon up down here, and you can see I'm now telescoping the 6 guide liner all the way out to the distal vessel. And that process of just sort of walking one on the other side of the other, it gives you incredible backup. And so, you take a case that, I mean, this case I think physically can't be done without this to deliver equipment downstream. And we're able to deliver, I forget what this is, probably a 3.538 that we were able to deliver throughout. And it's a nice technique. It's coming out sometime in the not too distant future in an article. But then you see
very cool. And then you said you saw 8 through 6, right? And it fits okay. The guide liner, the 6 fits okay through the 8, right?
It does. It does. Both the 5.5 and the 6 will both fit through an 8. Yes. So.
Wonderful.
So this is the one. Just showing. This is the one that's getting written up. But if you look here, this is another interesting case. This is a guy that had in-stent restenosis, real severe symptoms, and sort of a left dominant circumflex, and you have this sort of harsh retroangled takeoff of his circumflex, and you see what when we're looking at this. So everybody that does a lot of CTOs is always looking at other options, and so this is a pretty hard angle to get backwards on, and it's not so hard whether or not you'll be able to wire it, but you're not going to be able to track a microcatheter down in there to get the local backup support. And so we were able to do that. So we were able to use, I use actually Supercross 120 to get an angle at that, which I think is another place that catheter is very helpful for on these retroflexed circumflexes. And we were able to get a wire down to the cap, but you can see we can't track anything down there, so I've got no backup on the wire. So I mean, to get any kind of penetrating force was futile at that point, and we're just prolapsing back. But if you look, we had, let me show you here. I'm going to walk back a couple slides so I can show you. If you look, though, up here, you've got a vein graft conduit coming into, or essentially a ramus or a very high marginal, that has a much more favorable angle coming from there down at the cap. And so this isn't this kind of hard back angle. This is more of a straightforward angle, I thought. And so I thought, we'll come at this CTO and just do it from the vein graft backwards rather than do it from the native. And so that's what we did, and it was fairly easy to wire. The issue was the same, though. I'm going to catch up to that point. So we were able to wire that down, and I was actually able to flip the Corsair we were using at the time to get that down actually into the cap. And but you still weren't able to get enough penetrating force to do anything with. And so we switched out and went back to this same idea, this mother-daughter, granddaughter technique with this, which if you look here, we've got an 8 French AL 0.75 in. We've got a 6 French guide liner downstream and an 8 French guide liner backing it up. And you can see, so there's the 8 French guide liner downstream with the 6 French guide liner. and we're able to take the 6 French and ride backwards and go all the way up to the more proximal vessel, and then telescope the 8 French all the way down to that elbow point. And it's great, gave you, again, great backup. I mean, you're able to drill right through and finish the case, punching through the true lumen. So it's a nice thing to think of. It's a good backup strategy, and I think, for these vein graft cases, you oftentimes do benefit by having a guideliner in, and if you're not getting where you need to go with just one, using a second guideliner with the mother-daughter, granddaughter technique is a neat option. I'm going to show you some other cases here just to go through some of the strategies that we have, and we can talk about coiling or not coiling, and I'm curious to hear what your thoughts on that are, Manus. But it's just another example. This is obviously a CTO of the right coronary artery. This patient had, real degenerated graft. He actually has 2 grafts, one to the PDA and one to the PLV, and a pretty severely diseased native right, obviously, as well. And if you look, at traditional data, I mean, somewhere in some studies, I think in your, even the one you just published, Manus, I think it was 25% of the time that people are using distal protection when they're working on vein grafts. And, this is why a lot of times, I mean, there's just nowhere to put distal protection here if you wanted to. And then you also look at your data and you say, if your recurrent MI rate, and all the things that are the negative predictors of vein grafts occur at so much higher frequency than having done the native vessel, it really begs the question why you're ever doing vein grafts anymore. And I honestly, I don't remember the last time I did a vein graft PCI because we just use it as a conduit to do the native. And so we're almost really never doing veins anymore, and we're just using them as a avenue to go retrograde. If you look, so that's one graft that's degenerated, and then that's just another view of the same. But there's a second graft here that goes to a PLV, which you can see is also degenerated. And so those are 2 different limbs. And so this is a neat case because we thought that, you could potentially do the case antegrade, but, it's really going to be pretty predictable retrograde. And so we started out with the PDA. We've got basically an AL in our right. We have a Turnpike LP in there, a wire down the right, and that's just sitting there because, we're going to eventually need to likely do reverse cart. So you're going to need a wire at some point. We gave a half-hearted try to go antegrade here, knowing that we're just going to go retrograde. And so it is, a wire obviously all the way down, easy to wire because it's open, wires out into a septal here. And in this case, this has got that V conformation. You can see I've got the Supercross 120 down here. That needs to go past, and this is just reiterating what that is. They make them in all different shapes. I find a 120 to be, truthfully, the only one I use. So, I mean, I don't know if you like in a 90 or a 45.
Do you use much venture for this, or you just like this one better?
I like this better, to be honest with you. I mean, I think it's a little. I've not had any trauma to the vessel, so it always worries me with the venture. The tip's going to scrape and traumatize the donor vessel endothelium and end up with a dissection on those lines. It's also a little bit more awkward to use. This pre-shape, it seems friendly. It's easy to use, and it's actually very torqueable. And and I think that it's surprisingly good. I mean, and I really do like it. And so if you can look here, I just want to say this, but you can see how you can torque it to the direction you want. It initially was pointing down, and you're able to just turn it to the direction you want it to go. I'll let that play one more time here, but you can see it's not pointing in the direction we'd like it, but it's very torquable, and it's very steerable, and so you can get it in the position you want, and it just facilitates getting your wire back antegrade. And once you're there, you could trap out if you wanted, because, I mean, making this thing, if you think about trying to make that turn, this turn is a hard turn for equipment to make. It used to be a hard turn for the externalizing wires. So if you used to externalize back when all we had was, R350, the traditional old R350, or, it used to be hard, or even when we were using a Viper wire to externalize, it used to be very hard to push a Viper wire around that bend. That's not the case with sort of RG3 and the new R350 that tends to take this turn pretty easily when you go to externalize. But, excuse me, if you wanted to trap out to a microcatheter, like a traditional kind of, Turnpike, Corsair, or Micro 14 at this point, you could trap it out. This does track, though, and we're able to track it all the way around. And you can see we just came up here and did reverse cart, which I don't think we need to go into reverse cart and everything along those lines. It's pretty standard, I think, for everybody that would be interested in listening to this talk. But, and then you can go a couple different ways. I don't remember in this one, but, yeah, so you could So because of that harsh turn down there that you're making, you could externalize, and the wire has made it all the way up past this point, so you could externalize at that point. Or you could tip in, which is just showing a tip in. This is very easy to do. It looks like you're doing some magical, real operator skill dependent thing, but it's not. It's a joke. So what you do is you take the Turnpike or the Corsair that you were able to go retrograde with. So we've driven this Turnpike all the way up into the guide, put it in the elbow or the corner of the AL. It works with an EBU. You can put it in the corner of an EBU, and then bring the antegrade wire down with a regular bend on the antegrade wire, and they're both sort of forced into that curve or that shoulder there. And the antegrade wire, if you just touch the tip of the other catheter, will just spin and go right down, and you can just pull your retrograde wire out and run the antegrade wire all the way down. And for this case, we actually ran the antegrade wire all the way down and put it up into the graft. I mean, it gives you extra support, so you're not worried about losing that support that you have. So it's a nice way. I don't know if you tip in much. I like to tip in when I'm worried about putting a lot of strain on the donor vessel. I tend to tip in a lot with epicardial collaterals just because I don't like leaving, putting a lot of strain on the epicardials during the case. And I think for these kind of cases, it's nice to not deal with that big angled bend down there to go around. But you do lose, some of the backup strength that you get, obviously, by having an externalized wire. So, I mean, there's no greater rail than an externalized wire. So you are giving that up, but it's still, I think, a useful strategy. And so we stented that and treated it. And then what we did is went back and we were going to do the same strategy with the PLV branch. So you can see we've got the PDA captured. We've stented the right. And we're going to go down and do the PLV. This angle, even though it looks less kind of acute or retroflexed, the problem is you got no vessel for you to get any kind of wire purchase up here. And so we try to use these little extra branches. So you can see when we ran down, same thing. There's the Supercross down there to help me steer. And you can see how easily it directs the wire where you'd like the wire to go. So you're going to be able to steer the wire right up into the target vessel. And I went out that branch, which, I was kind of hoping would give me the support to track equipment around and maybe put a Turnpike right here and go retrograde. You could not, everything just kept prolapsing down. So if it's going to happen to you from time to time. I don't have a solution for that. I mean, I've thought about putting a second balloon down and block the catheter from being able to prolapse, but I'm not excited about the idea of inflating a balloon in the endothelium that I'm not going to cover at some point with a drug-eluting stent. I don't know if you've had other tricks or strategies, Manus, that you've found ways to be able to get the gear to make that turn if it keeps prolapsing down. You have anything that you do that's a neat strategy?
Well, I mean, same as you try the smaller one. So Caravella works fairly well for this. For one case like this with Caravella, where the same algorithm with LP might go very well. And then sometimes what we try to do here is we even use it as a just marker. Now, here don't have enough room, but sometimes you have enough room. You can put the wire as a marker and try to hit on the grade if there's a short occlusion, instead of going retrograde. I haven't used the balloon for blocking, as you said. It just doesn't make me makes me a little nervous. But just smaller microcatheter, get more support, and then use it as a just marker.
Yeah, and I think and that's what we did here. Is we just went and flipped the antegrade here, and this is wiring with a Turnpike by itself, which probably isn't advisable. But I mean, I've actually used it a number of times, but it travels quite nicely. But yeah, going down vein grafts surprisingly easily. So I mean, even in some of these occluded vein grafts, if you just take a Turnpike LP or a Turnpike spiral and start to screw it into the graft, it tends to just find it much like a crossbox would do, sort of bluntly. And we just wired this and stented. This I was just going to show you again. This is just more guide liner usage, and I know most people are pretty facile with guide liners, but I don't think you can do complex PCI without being awfully good with guide liners, and I think you need to really understand this technique of trying to drive a guide liner where it needs to go. You see, again, this is a big balloon up. This is a 30 or 3040 balloon. Guide liner at the tip of the catheter. As the balloon deflates, so when you go up to 15 or so, put the balloon down. And as it deflates, ride over the balloon as it's deflating. You got now your guide liner sitting here. Again, put the balloon out in front of it. As it deflates, ride the guide liner over top of it, so you can see the guide liner tip here. And then again, we're going to run the balloon all the way out here. So again, the balloon down, guide liner all the way out there. And so you should be able to drive a 5.5 guide liner or a 6.0 Guidezilla all the way where you want to go. So I mean, see, we've got it driven all the way out to the distal vessel. So stent delivery at that point in time is of no issue. I mean, you've delivered the guide liner, the stent's just going to come right through. And so we ended up with this, and I choose, so for me, coiling or not coiling the grafts that you utilized, I've become a lot more liberal with coiling them. We had one come back thrombosed, so that I left some competitive flow in the graft, and a sort of it's anecdotal or empiric or anecdotal, but if I've got what I consider competitive flow, something more than TIMI 1, TIMI 2 flow, that's significant, I've been coiling them now, and especially so particularly if I've gotten a nice result on the native vessel. So I mean, I think if you have a borderline result, I think you remember, if you're coiling that graft, you're committing to your result for that patient's long term. Coiling, for me, we just use typical coils. I usually use a millimeter or two bigger than what I think the target vessel is, and you can see we coiled. Sometimes use multiple coils just to make sure you're getting enough that it's going to close. Typically, we don't hang around and shoot these enough to make sure that they're closed completely, but they're going to close over time. So here we coiled both grafts, both the graft to the PDA and to the PLV, and you can see that's a 6 in the bigger of the two grafts, and you end up with a nice result with sort of kind of dual exhaust pipes going up from the previous grafts, but both grafts will close and thrombose, and you're left with a situation where you're not dependent on either of the degenerated grafts. And so, what's your coiling strategy? Are you coiling the same kind of thing if there's competitive flow, or are you not coiling, or
yeah? It's an interesting point. Actually, I must say I'm in the camp of I don't like coiling very much, because you say you may close the native, but then if you close the native now and you glue the graft, then it might be a problem. Now, right. Having said that, I think in a case like this one here you're showing us, this tremendous competitive flow, that makes more sense to close. But what I do in those cases, I don't know what your thoughts is, I usually, before I put a coil, just to avoid it traveling down, I will put a stent across the touchdown of the graft, like a regular stent, and then coil over it, so I minimize any potential risk of the coils, going down and traveling. And I try to coil a little further down, closer to the distal touchdown, than higher up. But again, I don't know what your thoughts are on how do you like to coil them, lower or higher?
I'm actually, I tend to go in the middle of the graft, so I tend to give myself freedom on both ends, because if you oversize the coil, or if you don't get it done coil entirely, I don't want a piece of it hanging out in the aorta. Right. And at the same time, I think by oversizing it to a degree, I've not had any kind of take off and head downstream, so I've not made the effort to protect downstream. I think it makes good sense. I mean, it's a another safety step to be in place to make sure that you're not going to have a problem, but by going up a size, like I think this is a 6 in that graft, and then the other ones are 4s in that graft. That was probably 2.5 or 3.0, and I've not had any travel to an undesirable location on me yet. So, there's another example. This is a neat case too. This is a guy that has had grafts, and you're going to get facile with these. I mean, this is always the debate, or always the argument that people have, should you have bypass surgery, or should you have, CTO stenting when people have CTOs? You can go either way, but I mean, we know the data. If it's a circumflex or a right coronary artery, I mean, you've got, depending on what studies you look at, but you look at PROG4 and you say, 70% of those grafts to a well-collateralized CTO are going to be closed in a year's time. So, I mean, you're going to be doing the CTO at some point or another. So it's just a matter of whether or not you want to wait a year and have a surgeon put another conduit in for you to use as your retrograde option. And that's what you have here. This is a guy that went for bypass surgery, had a totaled right, a totaled a left main, ended up with a lima to the LAD, and ended up with vein grafts to the right in the circumflex. The lima's working and everything else is closed, as we've all seen, a number of times in life. And so that's the vein to the right and the vein to the circ. Both are closed. Both are favorable in appearance. So if I go back to that right, if you look at the graft here, this has that nice little, what would have been that third picture that I showed, but it got a little bit of a bowl shape, but there is an entry point into a lumen, or into a channel. So this is the kind of one when you look at, like, if you show this to me, I'm thinking I'm going to be down this graft in 30 seconds, that it's going to fly right down, and it tends to be like that. It tends to fly very, very quickly. The circ is very similar too. The circ has, even though it's a little hazy in appearance, it tends to have that tapered tip to it. It doesn't have a little avenue to go down, but it has a tapered beak to it, and so it's very likely that's going to be very usable as well. And you can see, and that's just another example of what the right looked like at the beginning. The guy's living off his IMA, and it's giving off collaterals to everything. And unfortunately, if you wanted to do the right retrograde, these collaterals that kind of take off upstream from the touchdown are extremely hard to use. I've yet to meet anybody that's managed to go retrograde through all that and pull it off. But I don't know if you know somebody, but as of the last time I heard, nobody's pulled that off. So we started out antegrade, and you can see it's exactly what I thought. You know, the wire flew down through in no time, and I've got a turnpike down behind it. This is a very important thing to do. I was not convinced this was true lumen down here, and if you look here with a distal tip injection, you can see it's clearly stained. You need to know that this is in, and it was not in. It's with the vessel, but it was traveling beside the vessel, and I'll go back to that so you see that. So you can see downstream here, the wire tip is moving with the vessel, and it's moving probably with this little branch that kind of splits the uprights of the PLV and the PDA, but it's not in. And so you got a couple options at that point in time. You likely are not going to get in the true lumen without doing enough manipulating down here that you're going to create a compressive hematoma that you don't want. In my situation here, I knew I had that other graft, the Circumflex graft, and so I bailed on this almost immediately because I know if I open up the Circumflex left main, I've got access to all the septals. I can do this case retrograde via septal very easily. And so I actually walked away from this at the time and went to the Circ. And you'll see with the Circumflex graft, you know, again, down to the distal vessel. This was, again, in like 10 seconds we're down there. And this time you can see the tip is definitely in the target vessel. This is a difficult kind of anastomosis. This is one that's also flexed down. This is a tip injection to kind of show you it. So I don't do tip injections almost ever in life except for this situation. And so you're able to see the anatomy here. It's plugged shut, so you kind of has that kind of dissected, dampened look, but as soon as you pull back on anything, it all cleared. So again, we're going to use the Supercross 120, turn it the direction you need it to be, and you can see we're able to wire north up here and able to do true-to-true crossing actually into the guide and stent to the circ, leaving you access to the septals now to go retrograde back around. And so we're going to come back. That guy, I just saw him in the office today. We're coming back next week to use these septals and do the right. So, you know, you've used the circ graft to open up the left main to have access then to the septals again. So I'll show you this one other one just because this shows the wiring process.
One question on the previous case. So for those cases, I guess the other advantage of going the Lima, that's the last remaining vessel, right? So something happens there. I think you need to have a lot of healthy respect for what's going to happen in that case. That guy's got an ejection fraction of 21%. He's living off his IMA. It's the last remaining vessel. You traumatize the IMA, you thrombose the IMA, or if you kink the IMA while you're working and get him ischemic, you're going to, I mean, it's a case that you would definitely want to have some sort of mechanical support during the case, probably up front with protected with Impella. But even so, it's a disaster waiting to happen. And I think, you know, I do a lot of CTO PCI. I've, you know, done well over 1,000 cases, and you know, so I do not like working in IMAs, so I try to avoid them as my last approach. I mean, that's the one thing of value that the surgeons have to offer the patients, and I think, you know, to do anything to compromise that or traumatize that is just a disaster. So this is another one. So if you look at it, this is like the ideal one. So if you're going to go after and start tackling old dead vein grafts and use them as retrograde conduits, if you see one like this, it's like a dream. I mean, this is going to be an easy case to get into. You've got a nice beak leading you into it. You see this a lot of times in the circ grafts, and they're very easy to use. Same kind of setup. So we go up there, and if you look what we've got, you can see our target vessel downstream. It's a pretty nice target. We've got a nice looking distal anastomosis down here. It's tented up a bit, and it looks like it's kind of a Y where I'm going to easily be able to go left or right when I get down there, so I'm not too worried about doing driving the gear retrograde afterwards. And you can see this lead-in portion that we've got here. So the setup again on this is just a Pilot 200 with a Turnpike behind it. This is a Turnpike LP and a typical CTO bend on the Pilot 200. You see we're just digging a little bit to get into the cap, and so you can see that the wire progresses a bit here, and so it's forward a bit. And then take the Turnpike down behind it, and then get a little bit of backup, and you'll see how the wire just flies. And that's the way it travels the vast majority of the time when you're doing these. I mean, you can see how quickly, you know, that's going, you know, into the retrograde or into the distal vessel. So let me just play that again there. But you can see, I mean, this is little or no work
to get that to go. And I do think a pilot's probably your best choice. Pilot 200 is your best choice to start off. But once it goes, it always has this kind of tips-free, easily spinning, runs all the way out and catches a distal vessel. Again, in this case, we tend to split the uprights more than we realize, and this kind of caught a branch again, didn't go out to PDA, but we're definitely in the true lumen downstream. Just redirected the wire. You can see we didn't use any kind of special angled catheter. You just wire retrograde straight up into the target.
Do you use pilots for this, for the retrograde wiring, for going back, or you use softer wires, or what's your preferred wire when you go backwards like that?
Yeah, I use a Pilot 200 to start off almost all the time. That's kind of the weakest wire that I use, retrograde, and then I'm pretty liberal about Comprehensive Pro 12s and guys, second and third would be the other two that I would use. I know everybody talks about, retrograde wiring and using softer wires and so forth. You know where you're going. You're not, a lot of times you're driving it into a guide liner. You brought a guide liner downstream. So I don't know what the concern is about, wire exits we have happen all the time. And as long as you don't track gear behind it, it doesn't mean anything. It doesn't do anything. So, and if I have a guide liner there and I didn't wire the guide liner, I'm not going to track gear because I don't know where it is. So I don't have any real, angst or ambiguity. You've got, if it wired to guide liner, I'm going to drive up behind it. If it's not going to the guide liner, not going to the target vessel, I'm not. So I escalate very, very quickly retrograde and don't really de-escalate all that much, to be honest with you. And so this is just kind of a neat case just from the fact that, and I want to show you the last one before we run out of time. I think we have about 10 minutes, but we wired this true to true, actually. So I put an antegrade wire down just to use as a target to kind of lead me where I was going. And you can see we're right on top of each other, the antegrade and retrograde wires are. And retrograde, we wired pretty easily straight up in. You can see the wire's going to pop into the aorta here. We didn't catch the guide, but it's clearly in the aorta. The issue is we couldn't drive anything up through that. So even with a Turnpike, I switched to a Micro 14, made it a little bit further, but there's a cap there you just weren't going to get through. So we came back and actually did an elective, reverse cart here. This is something I was talking about with Bill Lombardi. Sometimes you cross these lesions true to true, and it's the worst thing you can do because you spend the next hour fighting all the intraluminal calcium and fibrosis, and sometimes it's easier just to go around it. And so that's what we did here is we just came back, made an intentional dissection upstream from it, and knuckled a wire antegrade and knuckled a wire retrograde, and did reverse cart around the calcified segment and just stented the subintimal space like we always do with reverse cart. But it's a nice way to just avoid dealing with the misery of the 10, 15 years of calcified vessel that's sitting in there that you're having to work through. I'm going to jump through this just because I don't want to run out of time. I want to show you the last case here.
Sure.
Watch this.
I will say, I'm going to skip this one, but I will say this is the one time I ever do ad hoc CTOs is patients that have ACS due to the graft going down. So I'm almost never do an ad hoc CTO. But if they're coming in with ACS and it's because the graft's thrombotic like this one was, that's the time that we will actually just do the CTO right there on the table, and that's what we did in this case. The last one I think has some value, so I just want to show it before we run out of time. This is a, let me catch it there. So this is an interesting case, and I'm not sure we still know exactly what happened in this case, but this was a Circumflex CTO that had a occluded vein graft going to it, and you can see the typical setup that we would normally have. It's an AL guide that we've got in the circ graft, and you can see there's a little beak going into it. It's more bowl-shaped than what you'd like to see, and we weren't able to progress much. This is a tip injection. It's sort of like a mini Carlino inside the graft, but we're making no progress. And I've knuckled before in grafts, and it's really not an issue. So I didn't walk away from this with a change in my opinion. I still would knuckle in a graft, but this is just a Fielder XT knuckled and aggressively knuckled. You've got a big knuckle here, but here's the stiff part of the Fielder XT leading it, and you can see we got that to go to a degree and push. But we're making no progress, and wasn't able to sort of straighten it out. A lot of times you make the knuckle and then recapture it, get the turnpike down there, and you can run a wire south. So we turn our attention just going back and trying to do the circ with a native strategy. But the patient, got a little bit unstable during the case, a little hypotensive, went back and shot the graft that we were in, and you can see what's going on here. So we've knuckled out to here. never made it down to here, but it basically, I think more or less transected the vein graft, you know, and so you can see a hole down here. And so you've got the graft more or less broke, and so you've got contrast pouring out into presumably the mediastinal space. I mean, this wasn't, there's no fusion on the echo there. The guy didn't develop tamponade on the table, but you can see, you know, we shoved a bunch of coils out there to close it off, and you can see the outline of this. And I don't know whether that's the left atrial appendage. I kind of get the impression it might be. You can see contrast still pouring out there. This did close, and we actually did not complete the case, but with about 37 coils, it finally shut down. But don't want people to think just because the graft is occluded and has been occluded that it is without any consequence, because although the vast majority are of no consequence, and I think, you know, distal embolization is a non-issue with this. People always ask, well, aren't you going to distal embolize all the thrombus and grummus that's built up in the graft? You're not, because you're never dilating the graft. You're just running a microcatheter down through. So distal embolization almost never occurs. But you can, you know, make some pretty egregious acts with this, and so you can see, you know, this fracture. This all turned out fine. The guy did fine, but it's just a lesson to be learned. You know, you can't have just total disregard for it with knuckling and pushing downstream. So that's where we are. We use them. The vein grafts have become one of my, you know, preferred initial conduits to explore before going to the other options. So that's all I have for you, Manus. I'd be happy to answer.
This is awesome. I wonder, do you ever? Obviously, this doesn't happen every day, but it's amazing to me. You got, as you said, a million coils in there, and there's still like a lot of flow around them. I wonder if in a case like this, you put like a over-the-wire balloon and just put some thrombin down there, or.
I think you certainly could, especially given the fact that, you know, you don't have the same concern that you had when we were talking about the grafts with continued flow. I mean, you don't have a target vessel that this is going to go to. So I mean, I think you certainly could. We hung around and you did get a occlusion. I mean, typically the coils don't close instantly. So I mean, you know, and even the ones that we coil, you know, a residual graft, I don't hang around to watch those close. I kind of leave with the assumption that they're going to close. But you know, nothing like you're saying closes instantly. But you can see this is closed now at that point, and you've got sort of stain or contrast hanging up behind it. But putting thrombin down there, you know, would work as well. We use thrombin not infrequently for epicardial or epicardial perforations if we have them. Just like the duet that used to be the closure device, you know, just for they would use for a pseudoaneurysm injection. The same thing, you just the smallest little bit out the tip of the microcatheter will shut it down. So you could use it here as well.
Wonderful. These are phenomenal cases. Well, some questions that came through in the meantime. Do you ever use any crossbows for this, for these occluded vein grafts, or you don't use much crossbows for those bypasses?
I have not. I mean, you can see intuitively it might be nice to sort of blunt the sect and stay in a true lumen. My thought is you're probably going to struggle with having enough backup to get it going, and it just hasn't been an issue that I've had to use. I think most of the time you're able to wire pretty easily. So have you? I don't know. Have you used it?
Well, you know, I've done it, especially the ones that I think are younger. It works pretty well. Of course, you know, I don't have, you know, in those cases, it's possible that the wire might get just flown down as well. So it's hard to know for sure if it's the crossbows or not. I used them a few times because I had this issue where I went like you saw, I went down the wire and then I dissected the whole graft without realizing it. They couldn't get back in at the end.
Yeah, so that's a real issue. I mean, I think, you know, people need to pay attention to that when you get the wire downstream. It will attract the target vessel too. So I mean, you go right through, and you think you're good, but I mean, you've got to have some sort of confirmatory picture, because once you track gear down there, you're going to compress everything if it's subintimal.
Yeah, absolutely, I agree. But it actually, it's funny. Yesterday we had a case. We went down retrograde through a vein graft, and halfway through, just the wire just kept going in funny places, and then took a picture. There's all this big stain, but I mean, it was not going anywhere. It was stable, so we left it alone. But it is interesting feeling when you see the stain, I guess, in the vein graft. Makes you wonder where
you're at. Yeah.
It's going to. Wonderful. Well, again, that was a phenomenal talk. I think, as you said, I think people are more and more trying to use these bypass grafts for these cases. Now, there's this concern about the localized tamponade when you go to the bypass patients. Do you think it's less of an issue here because these are higher up from the pericardium, or are you still concerned for like localized tamponade if a graft bursts for some reason?
I've not had it with a graft issue. We've had certainly more cases of localized tamponade than I'd like to remember, but I mean, you know, I think that I've not had issues with it with the grafts. You know, I think it's more of a product of big dissection processes in the true vessel. So, you know, when we've had it the most times is when you end up with big knuckles, either antegrade or retrograde, and shearing off side branches. And oftentimes when those knuckles, you know, track an RV marginal that you wish it hadn't tracked, and it tends to be then when you see the hematomas form on the RV free wall and you get the dry tamponade, so, which is a miserable thing to manage. But, you know, I've not had it with grafts.
Okay, great. Great. Well, I mean, that was a phenomenal presentation. We really appreciate it very much. That was a lot of tips and tricks there on how to do it. To be honest, you really made me try more the Supercross. I haven't used it for a while. I love to use the Venture, but I mean, I love to see your cases how it works pretty well up there. So I'm excited to try it again. And of course, the microcatheters, the low profile work as well. So that's a very useful tip and trick.
Great.
So thank you very much, Bill. That was a wonderful presentation. Again, we'd like to thank Dr. Nicholson for an outside presentation. Thank again Dallas Research Corporation that sponsored today's webcast and sponsors Terumo and Abbott. And again, thank you all. Look forward to having you in our next webcast. So thanks again, Bill. We really appreciate it.
Thank you so much, man. It's great to talk to you.
Thank you. Bye-bye.